Speak to you today on the topic of carcinoid heart disease. I have no disclosures. I'm going to start with the case that was referred to our institution of a 70-year-old male who was diagnosed with carcinoid with liver metastasis in 2012. He had an elevated 5-hydroxyandoacetic acid level at diagnosis. He presented with shortness of breath and lower extremity edema. On presentation, he was pretty cachectic. His BMI was only 17. He had a holosystolic murmur at the left sternal border consistent with TR, and he had evidence of volume overload with decreased breath sounds bilaterally, extensive ascites, and 2 to 3 plus edema. His treatment up to that point included staged embolization of the liver and octreotide monthly. And then he failed that. He progressed, his disease progressed on that. He went to a combination chemotherapy, which he did not tolerate, and then ultimately was changed to a targeted agent along with octreotide. And on this treatment, he had some regression of the tumor burden in his liver. This is his ECG, which shows low voltage, which is typical of patients with carcinoid for reasons that I think we don't really understand. And here's his echo. We can see that he has severe right ventricular enlargement, RV dysfunction, and an underfilled LV. This is his RV inflow view. This is a classic image of a patient with carcinoid. His tricuspid valve leaflets are thickened. They're fibrotic, very rigid, and retracted, and held in a semi-open position. So through this malcoaptation, he has severe tricuspid insufficiency, and you can see accelerated flow going back forward across the right ventricle. On his spectral Doppler, you can see a dense, triangulated TR waveform, as well as increased flow velocities, again going forward across the RV with a transtricuspid gradient of 6 to 7 millimeters of mercury. So probably some component of mixed TS and TR, with TR being dominant. And here's his pulmonic valve, which I must admit I can barely see, but you can appreciate that there's some thickening in the region of the pulmonic valve, and that is associated with at least moderate, probably moderate to severe PI. The transpulmonic velocities were elevated also with a peak velocity of 2 meters per second and a transpulmonic gradient of approximately 17. So there are a couple of disease processes that carcinoid may be confused with. One of them is rheumatic heart disease. You can see the image on the left. The tricuspid valve leaflets are thickened again, particularly the leaflet tips, and they're also retracted. There's malcoaptation, and certainly there can be tricuspid stenosis with rheumatic disease. However, unlike carcinoid, rheumatic disease would be unusual to see only with right heart involvement. It's typically seen in the presence of left heart disease. In fact, rheumatic disease tends to prefer the mitral and aortic valves. Liebman-Sachs onto the right is another entity in which you might see thickened leaflets, though usually the leaflets retain their pliability, and these patients have other diseases, rheumatologic diseases. So why does this happen to the leaflets? What exactly is happening here? It's thought that the tumor secretes vasoactive substances, including 5-HT, which is serotonin, and that has fibroblast proliferative properties. That causes activation of 5-HT2B receptors on heart valves, and these receptors are very plentiful on the heart valves. Together, this induces mitogenic effects of fibroblasts and smooth muscle cells, triggers inflammatory pathways, and upregulates TGF-beta, all of which leads to fibrosis. At the same time, there's a deficiency of the 5-HT transporter that's responsible for 5-HT uptake and inactivation in the lungs. So basically, you have excessive circulation of serotonin. So I presented our case where we had a patient with TR, and right-sided valves, as I mentioned earlier, are most affected. In this series of 250 patients with carcinoid syndrome, 52 had evidence of carcinoid heart disease, and tricuspid valve was involved in 90% of the cases, followed by pulmonic valve. And only about a third of the cases had involvement of the left-sided heart valves, with equal distribution of the aortic and the mitral valves. In those patients with left-sided heart valve disease, 87% of them also had a PFO, and that's believed to be the mechanism by which the left-sided valves are affected because the vasoactive substances bypass the inactivation in the lung. So carcinoid heart disease is a pretty rare bird. Neuroendocrine tumors in general are rare. So within the general population, neuroendocrine tumors happen in 2.5 to 5 cases per 100,000 individuals. And of those with neuroendocrine tumors, 30 to 40% develop carcinoid syndrome, which is the syndrome marked by diarrhea, flushing, and bronchospasm. And of those, 20 to 50% develop carcinoid heart disease that you've seen today. So how do we identify patients who have neuroendocrine tumors that might be at risk for carcinoid heart disease? There are 2 biomarkers that are helpful in this regard. 5-HIAA, which is the level that was elevated in our patient, is used to diagnose and follow carcinoid syndrome. Both the 24-hour urine levels and plasma levels are associated with both the development and progression of carcinoid heart disease. The urine collection is a 24-hour urine, so it's a little cumbersome, and the results can be influenced by medications that can cause either false positives or false negatives, so one needs to be aware of that. The plasma levels are more convenient, and in a recent expert consensus document, it was recommended that they could be used in place of the urinary levels whenever available. NT-proBNP is a biomarker that we're well acquainted with. It too is associated with the development and progression of carcinoid heart disease, and levels correlate not only with the degree of RV enlargement, but also with survival. What about echo as an imaging biomarker? Bhattacharya and colleagues really did a very nice description of the range of findings one might find in carcinoid heart disease, and really kind of laid out carcinoid as a spectrum of disease in which in the mild form of the disease you might have some heterogeneous features, a little bit of thickening of the valve, perhaps some loss of pliability, and really mild trace or mild functional abnormalities. But by the time you get to more severe or advanced disease, you have a patient that looks much like our patient with fixed and retracted tricuspid valve leaflets and severe TR with RV enlargement and even some subvalvular involvement as well. The findings for pulmonic valve disease follow a similar trend. There are a variety of echo scores that can try to put a quantitative spin on these features of disease, and again, Bhattacharya and colleagues used an echo score like this one presented to try to determine if there was a way to predict who was going to have advancement of carcinoid heart disease. And they found that when a score increased by greater than 25%, that suggested a progression of carcinoid heart disease in about 18% of patients with carcinoid syndrome who had been followed with serial echoes. What about our other imaging modalities? We have several that are complementary in this disease process. 3D echo can be helpful to delineate how many leaflets are included in the disease process and also to view the subvalvular apparatus in a way that's difficult with 2D. It might be better than 2D to ascertain whether there are mass lesions, myocardial mets, compared to 2D, but honestly, I think if you're really looking for mass lesions, you'd probably be better off with MRI to quantify the number and the size and the location of those lesions. They don't tend to enhance on late gadolinium enhancement, so you can just use a simple, straightforward MRI. And we know that MRI is good for calculating RV volumes and ejection fraction. However, if you detect a mass, you still need to know if it's biologically active, and so the gallium octreotide PET scans are useful for that because any avid lesion would suggest tumor. So how do we know who and how to screen? So the recent expert consensus document indicates that for patients with metastatic neuroendocrine tumors that biomarkers and specifically NT-proBNP and an exam be performed every 6 months in these individuals. And if the NT-proBNP exceeds 260, then to proceed with a transthoracic echo with bubble study. And if the echo indicates evidence of carcinoid heart disease, then referral to a cardiologist is needed for medical management and ultimately consideration of surgical intervention. However, the things to consider prior to any surgical intervention are whether the symptoms are likely coming from the carcinoid heart disease itself or from the metastatic process, such as the involvement in the liver. It's important to know what the prognosis of the patient from the carcinoid perspective, and also what treatment options are left for this individual, as well as the bleeding risk, because these patients have significant liver disease and often have coagulopathies. With all that said, operative mortality used to be quite high, maybe more than a decade ago. And this is data from both the Mayo Clinic series and also from a Mount Sinai series. And what you can appreciate here is that the mortality, as depicted in the curves, has decreased significantly over time as the volume and experience at the various centers has increased and patient selection has improved. There are, however, some high-risk subgroups, those with anasarca requiring inpatient diuresis, older patients and smokers, and patients who have been treated with chemotherapy other than octreotide, because that indicates a patient that might be more refractory to treatment. So if you're sending a patient to surgery, we need to consider which type of prosthesis to implant. And historically, mechanical prostheses have been implanted because there was some concern that carcinoid would involve the new prosthesis if a bioprosthesis was chosen. However, that turns out to be pretty uncommon, and yet coagulopathies that are associated with long-term anticoagulation for mechanical valves are not so uncommon. So now the pattern has changed so that tissue prostheses tend to be preferred and actually have a little bit of a better outcomes compared to mechanical valves, and the likelihood of re-op on either prosthesis is pretty similar. When you are choosing a tissue valve, the stented varieties tend to be favored, and the reason for that is that they overcome some of the issues that we see with homografts, which don't have that rigid structure and can actually be constricted by annular fibrosis from the disease itself. Of course, today we have a lot of percutaneous options for tricuspid valve and for valvular heart disease in general. Many of these are still evolving. There have been cases of a pulmonic valve replacement through an existing bioprosthetic tissue, bioprosthetic tricuspid valve. There have also been valve-in-valve replacements for tricuspid and pulmonic valve replacements in patients with carcinoid. And then lastly, there's been described a case of a transcutaneous pulmonic valve replacement and a transcaval implant to try to limit the backflow of the TR from hitting the liver and then allowing the patient to be diuresed. So in summary, carcinoid heart disease is uncommon but is associated with a poor survival. It's marked by right-sided valve disease and right heart failure. Biomarkers like 5-HIAA and NT-proBNP are helpful for the detection and prognosis of carcinoid heart disease. Echo is the cornerstone of imaging for carcinoid heart disease, although it can be supplemented by complementary imaging modalities. Valve surgery has an acceptable mortality and improves New York Heart Association classification in well-selected patients. Thank you for your attention.
There's a question from the audience. It's what's the role of the use of agitated cell line study in carcinoid patients to look for PFO?
Sure. So the reason to do a bubble study in these patients is to establish whether there could be shunting from really right to left. So you have these vasoactive substances like serotonin that get degraded in the lungs. However, if you're bypassing the lungs, those substances manage to circulate into the left heart, and then you can have left heart involvement. Left heart involvement is typically blamed on the presence of a PFO, but it can also happen if you have bronchial carcinoid or if you have just so much circulating vasoactive substances that you're overwhelming the degradation process in the lungs.
That will conclude our session. I'd like to thank our speakers for 3 excellent talks. Thank everybody for your attention and wish you a great rest of the meeting. Thank you very much.